Good morning, everyone. Thank you for coming out on Sunday. My name is Jenny Nachmus, and it's my pleasure to introduce our speaker today, Delma Armstrong. Delma Armstrong is a nurse navigator for UNC Breast Cancer Center at the NC Cancer Hospital. She has worked at UNC for 20 years, spending the past 12 in the breast center program. And she's held numerous offices in state and national nursing organizations. In 2011, she received a Nursing Recognition Award presented by the UNC medical staff for her contributions to patient care, teaching, and research. So please join me in welcoming her.
Thank you. Good morning. We're going to fly through some basic information, but I think that for me, the real meat of this session is whatever questions and answers that we have and whatever I'm able to answer. I've been a nurse so long that I think a lot of the science for me is really integrated, and what I spend a lot of my time doing is breaking things down for my patients. The physicians I work with said, well, there's the science of breast cancer and then there's Delma science. So you might get a heaping helping of Delma science today. Find my thing. I was charged with talking about medical terminology and test results, and basically what I've done is crafted some slides around the test results. What I'd like you to do, if you do have questions about any of the medical terminology that you hear a lot or that has caused you problems with getting your brain around, or that I bring up, make a note and let's talk about it after I've flown through my basic information here. So I wanted to talk about what kinds of tests we do in the metastatic breast cancer setting. And these tests may be samples of blood that are easily gotten at your doctor's appointments. They may be tissue tumor samples, such as biopsies, or we may get information from radiology, from scans or x-rays or ultrasounds that folks have to investigate a new complaint or an abnormality. And I'm going to go into detail about all of these just briefly. But first I want to talk about a couple of other aspects of testing. One is, what kinds of things do we need to know? Well, first we need to know, why are we testing? What are we looking for? Are we looking for indolent disease that may be coming back pre-symptomatically? Are we looking for a change in those blood markers, is what I'm particularly thinking about, before the patient's symptomatic? Are we looking to monitor our therapy? Are we just looking to see, well, is this really the way we should be going? So what are we going to test? Many times we use things like blood chemistries and tumor markers, and of course we use the complete blood count, which I'm sure you're all familiar with, that CBC, I see heads nodding, when you're on any therapy to make sure that we're not hurting you with our drugs. But just what are we going to test? And then I think one of the real money questions is when? When are we going to test? How often are we going to test? What's an interval that's good for me? All these things are discussions that you'll have with your medical oncologist, and you guys will push and pull a little and you'll work out something that you're both happy with. If you're on a clinical trial, that's the only case that's different. If you're on a clinical trial, the clinical trial is going to mandate what is being monitored and how often. And the only time that would change, and this is the answer to this bottom question here, what might change any of these? The only thing that might change what, when, and why is you. What's going on with you? A new symptom, a new problem, a new side effect we didn't anticipate. Any of those things may change what's being done. So this is the $24,000 question, right? Who knows how much everything costs? I can tell you it's expensive. I can tell you that all of my patients meet their deductibles, and that time when you're in that window of having to pay real hard money for things is very difficult. I think it's important to know that insurance reimbursement can vary widely even when the same provider in the same system orders something. If you can have the test done at an outlying clinic rather than under the hospital umbrella, you may get a reduction in the price. Your insurance company may have a contract, in fact, to do that. Another key thing about insurance that I would like everyone to know is that most insurance companies offer case management. And I think that metastatic breast cancer patients who do not have a case manager at their insurance companies should ask if that's a possibility. A case manager is a nurse like me who's been trained in the clinical aspects of breast cancer. My interactions with case managers through the years have, for the most part, been wonderful. They are advocates for their patients with the insurance company, and they often help me. We're often the people in the middle putting on the gloves to try to get something done. So I have found that to be a great relationship for my patients and especially for me. So do you know who in your healthcare system that you can go to ask about cost? I think the other important thing is to know a person, have a name and a direct phone number. It's really frustrating to be routed to billing all the time, particularly if you're in a system as big as ours. So that's one of the things I can facilitate. I get asked a lot of insurance questions. I know nothing. I can't even figure out my own. So I try to help folks get plugged into the people, not only who can answer their questions, but who can maybe help you set up a payment plan if you're going to continue to get your care. And that may be another factor when you're talking to your doctor about how often you're going to get scanned. I've been pretty stable for a long time now. Do we really have to do this every 2 months? Can we talk about every 6 months? Is there something else we could look at in between, like the tumor markers? Those kinds of things. But the other cost that I haven't mentioned yet, shame on me, is the anxiety. I think one of the biggest problems with the breast cancer journey is the waiting that people have to do. The waiting you have to do between the abnormal mammogram and the lump and finding the diagnosis. The waiting you have to do before you get those first appointments. Anytime you have to wait for something that may be a key element in your care, it's crazy making. It's just crazy making. And so, one of the things to keep in mind when you're talking about testing with your physician, more tests may actually lead to more tests and more waiting, and may actually lead to more procedures. It may be necessary on your path, but then again, I think that's a conversation to have with your physician. I think I mentioned this a little bit. Primarily, the things we use tests for, whether it's blood tissue or scans, is to monitor disease activity. Okay, we're trying to get a heads up on disease before it's really reared its ugly head. To monitor treatment effect, if you're on a therapy, we may want to do blood tests periodically and scans periodically to make sure that we're on target, and to inform treatment decisions. I think there are a couple of other scenarios where we do monitor people. One of those is when you've, like our speaker, had a solitary metastasis that has been treated. So you've had a lesion in your liver that's been removed, and you've had, or like her, that just dissolved away to a scar. And your doctor's going to keep you on a short leash for a while to make sure that that cancer is really at bay, that we really got all those rogue cells. And there is a term that we use for that, and that is stage 4 NED. And NED meaning no evidence of disease. So I have several patients who fall into that category that we see either every 6 months or every year. We might get a scan. Sometimes their insurance dictates what kind of scan they get, that sort of thing. So, and anytime one of those patients would call me with a new symptom, we would have a short leash to investigate, okay? So blood test, I mentioned the complete blood count, but I'm not going to go into detail about that because I think anybody who has had any treatment is probably very familiar with the test that we do to check your red cells and your white cells and your platelet counts and make sure that we're not impacting those with chemotherapy. The CBC can also be helpful in giving us a red flag about bone mets or bone marrow mets. So if you're having a sudden drop in your CBC and there's really no reason for it, then that may prompt further investigation. So it can be a helpful test. I just left it off my slide. So in terms of blood chemistries, we do look at things that indirectly give us information about your organ systems, and then we also look at tumor markers. The chemistries, I put in the most common ones that we use. We often check liver enzymes, whether or not you have liver mets. The liver is a common site of metastasis for breast cancer. I always think of those things close to the breast, the liver, the lung, the bones are all very common sites of breast cancer metastasis. So we check your liver enzymes, particularly if you're on any kind of therapy, whether it's oral therapy or intravenous therapy, because almost everything we give you is going to have to be filtered through the liver. And so we want to make sure that we're not impacting that adversely. And then we will periodically probably check some electrolytes, make sure that your hydration status is good. Your BUN and creatinine to check your kidney function. For bone health, we might be checking your calcium, phosphorus, magnesium, and even albumin. Albumin can, which basically is an indirect measure of your nutritional status, it's your protein in your blood, can impact your calcium result. So we may have to, if you're a little bit on the malnourished side, we may have to adjust those results to get the real figure. We're going to test those before any bone-directed therapy that you may have, such as a bisphosphonate or denosumab. And then glucose is the other biggie that we often are screening for. Steroids, of course, will raise your blood glucose levels, and we use steroids like Skittles. We use them as pre-meds for our chemotherapies often. We use them for nausea. We use them to manage all sorts of side effects, and even to boost energy during a low period. So the problem with steroids is they do raise your blood sugar, and we know that. And if the steroids are very important, then we may have to balance that with some blood sugar therapy. And then there's at least one newer medication on the market, Afinitor, which is a biologic agent that's given with hormonal therapy. I like to think of it as the reboot to the hormone receptors, and it can actually tweak people toward diabetes, type 2 diabetes. So, that's often a reason we have to stop that drug. Not often, but I've seen 3 people have to stop Afinitor. Interestingly, even though they were only Afinitor for just a few months, they've continued to have the good effect from that drug and have started back on hormone therapy with good results. So I find that fascinating. Advantages and disadvantages of tumor markers, they can be really helpful. They're quick and easy to do. I'm not going to say painless, because we all know blood draws aren't painless even if you have a port. But they can be very helpful in helping to make therapy decisions and also investigative decisions. You're having a new symptom, your tumor marker's a little up, maybe we should move your scan forward. The problem is they're not conclusive. So a negative tumor marker doesn't necessarily mean there's no cancer. You may not express that particular tumor marker. Not everyone does. So maybe I've heard numbers from 70 to 90% of women will have a tumor marker that can be monitored. But that means there's still that 10% or 10 to 30% that whose disease may not reflect well in the tumor marker. A negative result is not necessarily the absence of cancer, and a positive result is not necessarily a growing cancer. So one of my take-homes for this particular talk is right here on this slide, and that is that a change in therapy that is working and causing cancer cells to die may actually cause your tumor marker to go up. Okay? It may go up for a few weeks, it may go up for 2 or 3 months. The tumor markers are basically proteins that are made in response to the presence of the cancer or that are actually part of the cancer cells. So if you have cancer cells that are dying and we happen to check your tumor marker 3 weeks after a change in hormone therapy, for instance, we're not going to know if it's true. It may be tumor flare. It may be that the cancer is actually called the tumor marker to go up. So it's just something, something to keep in the back of your mind. The best tests that we do have for breast cancer are these, the primary ones being the 15-3, 27-29, and CEA. And I'm actually going to narrow that down to 27-29 and CEA. The CA125 is in there because occasionally, maybe once or twice a year, we'll see women who are diagnosed with metastatic breast cancer who think they're going to the operating room for an ovarian cancer. And it turns out that once that tissue has been examined under the microscope, oops, not ovarian cancer, look at this, it's a breast cancer. And then there's backtracking to try to find the original site of disease. So it can be a very useful marker, particularly in women who may have metastases to the ovary, who may be at risk of that, or who have already had metastases to the ovary. So typically we'll check the CA2729 and the CEA early on just to see if these reflect any changes for you. The CEA is primarily used in GI cancer and colon cancer, and it's used frequently as a marker there. It's not specific to breast cancer. And people who smoke will have an elevation in CEA. So that's one of the things about all of these markers is that benign conditions or diseases, things that are happening in your body can reflect the tumor marker as well as cancer. So they're ballpark numbers. Trends are important, but you know the actual numbers may not be so helpful. So we do use them to monitor therapy. And one of the most important reasons to do them is if you're having a low tumor marker that's not changing, then you and your physician may decide, well, maybe I don't need this scan every 3 months. Can we move it out to every 6? As long as this trend is continuing, I'm feeling good. Oh, and by the way, we're going to the Bahamas next week, and I won't be able to get in here for my Herceptin. Okay, so those things can really help to cut your costs down, and I think probably, of course, if your tumor marker is increasing, as I just explained, it's not as clear, okay? When you have a tumor marker that's increasing, what's important is a trend. Has it been on the uprise for 2 or 3 months and you're still feeling the same? Then maybe we do want to scan you a little bit sooner or investigate a new complaint that you have. Then the other set of laboratory tests that we do is those on tissue. And I think hopefully everybody is familiar with the fact that we're going to try to get tissue, particularly for a first diagnosis of metastatic disease. We're going to want to get tissue for 2 big reasons. One is we don't want to give you a stage for metastatic breast cancer disease, based on one data set for a scan, for instance. We want to see that you've got cancer in that bone or in your liver or your lung. We want to document it before starting any treatment, if we can. It's not always possible. So if we can, we're going to go back and we're going to do the same tests on that tissue that we did on the original breast cancer. Okay, we're going to want to look at the ER, the estrogen receptor, the progesterone receptor, and the HER2/neu status. I throw all of these things in a bucket that I call growth factors. And their presence means 2 things. One is they're telling the breast cancer to giddy up. And the other is we have therapies that we can direct at these agents. So they're all scored on a scale of 0 to 3, 0 being the no presence of the substance. 1+ is a little bit, 2+ is a moderate amount, and 3+ is a whole lot. Estrogen and progesterone receptors may also be graded as a percentage, but usually the pathologist will include the 1, 2, or 3+ as well. The HER2/neu 0 is none. 1+ is considered negative. 2+, on the other hand, is considered borderline or intermediate, in other words, on the fence. We don't really know if it's negative or positive. 3+ is definitely positive. So if you have a 0 or a 1 or a 3+ on your immunohistochemistries, at least where I work, we're not likely to do the extra FISH test, which is a molecular genetics test. It goes in and looks at how many copies of the HER2/neu oncogene are present on the cells of the cancer. And then it gives a big fancy number that, frankly, I can't explain. But it does tell us more specifically whether or not your tumor has amplified this HER2/neu oncogene or not. So the result when you get a FISH is going to say not amplified or over amplified. And occasionally it will say borderline, which is not real helpful. The reason we do these is to guide our targeted therapies. Okay, if we can address the metastatic cancer with a hormone blockade and or HER2-directed therapy, then those are very good places to start. One of the reasons they're very good places to start is they are so effective. Okay, they are extremely effective, and more. I would venture to say, for most people, more effective than chemotherapy, and they are well tolerated by most, which is not to say that hormone therapy doesn't have terrible side effects or that Herceptin, Tykerb, and Perjeta can't have terrible side effects. But for most people, they are tolerated well and help us to keep the chemotherapy on a back burner for when we might need it down the road. So other than lab tests, the types of things that we can do is image your body. And I'm going to talk a little bit about the imaging because the scans are all very different and there are very different reasons for doing them. And again, there's a cost factor to consider. Excuse me. X-rays, diagnostic X-rays would include things like plain films. We might check your ribs if you've had a terrible, horrible cold and you've got pain in your ribs that's not going away, and we want to see if you have a fracture there. Not that we can do a whole lot about it, but we might just want to know. If you have new pain in a hip or any bony area, it's a really quick, we can probably get it added on at your doctor's visit or done the same day at an outlying facility test. So it's really good for bones. It's really good for things like fluid levels in the lung and abdomen. So sometimes people have fluid that oozes from the lining of the lung and causes a pleural effusion. If that's happened to you before and you have shortness of breath, the quickest way to see what's going on may be just to get a chest x-ray. Okay. Ultrasounds we do use, and this is the only slide you'll see with ultrasound on it except the one at the end about cost. And the reason for that is we just, unless we're looking at a breast or lymph nodes, whether they're in your neck, over your clavicle, we really don't use ultrasound a lot except as a guidance to get tissue. So if the radiologist has looked at your CT scan or your MRI scan or your PET scan and said, yeah, there's this little area in the liver we would like to sample and we think we can do it by ultrasound, that's great. It's lower cost. It's easier for you. It's easier for the radiologist. It's pretty much a direct, and they can see what they're biopsying, okay? So they do a scan first to make sure that they can see the area in question, and then they can biopsy that. And they can do the same thing using some plain x-rays called fluoroscopy. This you may be familiar with if you've ever had a port put in. The real-time x-ray that they're doing that looks like a little bit of video, that's called fluoroscopy. Fluoroscopy, of course, uses a lot more radiation than just a plain film that takes, under a second. CT scans are used a lot. We can pretty much check the whole body with a CT scan. And the advantage of CT scans over plain x-rays is when you get a plain x-ray, it's kind of like looking through a balloon. Okay, you get things that overlap. So your bones are going to get in the way of the lung behind the bones. Your heart is going to block out some of the structures. So things overlap and you don't always see the whole picture, which is why we often do x-rays from at least 2 different perspectives to try to grab those missing data points. With a CT scan, when you're on that table, and I usually describe it as a donut with the tongue blade moving through it. When you're on that table, what's happening in that donut is a continuous x-ray, usually that's going in a circle or from many different points to acquire the information on your body. The computer takes that information and then turns it into a picture that looks more like a bread loaf, and I have a picture I'll show you in a second. But that avoids the overlapping structure problem. We can look at things down to just millimeters in thickness to find abnormal areas. MRI scans we do use a lot. It's not a total body scan, and because with the way the MRI does is, if the CT is like a donut, the MRI is more like a toilet paper tube. If you've ever had one, you know that those TP tubes are getting smaller now. When I used to work in radiology, if you were getting your brain done and your head had to be in the center of that scanner, your toes were the only thing sticking out. But I think those are getting shorter now, and the inside of them is getting bigger too, which is good, because those can be limitations for this study. You know, if you're too big to get in the magnet, and nobody in this room is, but you know, that can be a real problem. The other problem with MRI scans is it's like time-lapse photography, so you have to lie very flat and very still during your scan, and they are looking at one part of your body, so they have to use an antenna that hones the signal in on the area they're interested in. So if they're looking at your liver, they're not getting good pictures of your spine like we would if you were having a CT scan and we were seeing all of those structures through the slice. Does that make sense? So it has really good utility in a more limited sense, and it's the best scan to do for brain or central nervous system, brain and spine in particular. It's also a very good scan for lymph nodes. That may be a problem in the neck, the clavicle, the axil. I'm going like this because we're often checking the brachial plexus. So it can be a good roadmap for a surgeon, for instance. So here's a picture of a chest x-ray, and you can see why it might be a problem with those overlapping structures to see everything that might be going on there. I put in a picture of a bone density scan here because it's also a plain x-ray type technology that we use to check your bone density. And as you can see from the microscopic pictures there of normal bone and osteoporotic bone, normal bone is more dense. And that's really what we're checking with these scans is how dense your bones are. Since hormone therapies and chemotherapy can affect your bone density, then...
The two full figures, why is one of them a skeleton and one has got lots of...
Well, wouldn't that be nice to know? I don't know, Brenda. I really don't know. They do a total. Well, sometimes they're just looking at specific areas like the hip or the a specific area in question. The spine, the hip are the most common, and typically the images we see are like those on the left. I suspect the image may look like the one on the right before it's tweaked. But I do not know. This is a normal bone density scan. And then here's a picture of the CT scan, the bread slice I was talking about. The nice thing about CT scans is they can not just do bread slices, but they can also do slices down the front of your body and the other way as well. I mean, they can get all sorts of different configurations of slices if they're looking at something. These are kidneys and spine. Liver, some stomach up there with the wrinkly lining and fluid in it. And then the other picture I put in just because it was so cool. The other thing that CTs can do is they can reconstruct a 3D image. And the radiologist can take those images and watch them turn around. It's really good for surgeons who are looking for blood vessels in an area that they're concerned about. And I don't know if there's anything wrong with that lung or not. I thought it was a cool picture. This is the MRI scan. As you can see, looks a lot like the CT scan. It's a little bit fuzzy over here in the breathing area, and that's probably because those structures move while you're breathing. So since the MRI is capturing things in a time-lapsed manner, there will be some motion artifact in areas that move. But it gets really nice pictures of the tissue planes, particularly when we're talking about bone, muscle, and central nervous system. They can even tell gray matter from white matter. So it's a wonderful scan for that. This is a nuclear medicine bone scan, and it is a normal bone scan. And this is the one where any of the nuclear medicine scans that you have, you go to the nuclear medicine department, And it's like, I call it an inside-out x-ray. The radiation is given to you, and it's picked up by the part of your body that we're interested in looking at. And then it is, the information is gathered with gamma cameras. And the techs really get mad at me when I say they're like Geiger counters. So they use the gamma cameras to see where the radioactivity is exiting the body. So for instance, in a bone scan, the radionuclide is going to be partnered. It'll be technetium-99, and it'll be partnered with a phosphorus compound, because phosphorus has an affinity for bone. They'll give you an injection of this, and sometimes you can see the injection site, and I suspect it's that little dot right here where it was put into the vein. You can often tell because it's often right here at the antecubital. So, so the injection is given, and they tell you to get up and walk around for a couple hours, drink some fluids. They want you to move around. It takes a while for the phosphorus to pick up the stuff, yeah. And then, as you can see, the shoulders have spots in them. This is what they're looking for. They're looking for hot spots. This is a normal bone scan, so I'm going to guess that this is a degenerative change for this patient. So any area that gets a lot of wear and tear is probably going to show up. Any area that's had an infection in your bone is likely to show up, and then also bone metastases. It's a very sensitive test for bone mets. And this is a picture of a PET CT scan. As you can see, the nuclear medicine part of the scan, the PETS part of the scan, is kind of fuzzy around the edges. Those nice colors, and no, I don't know what the difference is in the colors. I suspect the red is more uptake, and the cooler colors are less uptake. With the PET scan, the radionuclide is attached to a sugar. And the theory is that since cancers are more metabolic than surrounding tissue, they will show up with this sugar. So when you get your injection in for your PET scan, they're going to do the total opposite of the bone scan. They're not going to tell you to go out and walk and drink lots of fluids. They're going to put you in a recliner and say, just breathe. Let me know if you need anything. Because they don't want to get pretty pictures of your muscles and your legs. They want to see what's going on in your internal organs. So they can see your internal organs, they can see your bones, it's a total body scan. Of course, with breast cancer patients, what we usually do is from your neck to your knees, okay? The amount of activity we have in our brains often obscures any brain mets. So the better scan for this, if anybody suspects brain mets, is the MRI. Okay? We just don't trust this one. Here's a nice busy slide that just basically compares costs of the technologies involved. So the more complicated the technology and the more complicated the contrast you might need for that, the higher the cost is going to be. The older technologies, X-ray and ultrasound, that don't typically use much contrast. Some X-rays do if you're looking for kidney stone and they're doing a intravenous urogram, then you know, you'll have a higher charge. But and then there are different advantages to different scans. So these are the list of questions I think it's important for everybody to know when they're dialoguing with the medical oncologist about test. Primarily, so what's the purpose of this test and how accurate is it? What are its advantages and disadvantages? How long is it going to take? That might be a better question for your nurse. Unless, of course, your doctor's had some personal experience with any of these, they probably have no clue. They often don't know that when they're ordering a CT and a bone scan, you're going to be at the hospital all day, or at least 5 or 6 hours, okay? So how will you get your results? That's a very good question. Who's going to call me? When are they going to call me? Is it okay for me to remind somebody? Who do I remind? That sort of thing. With the physicians that I work with, if there's a plan, then I'm often the one given results even if they're not positive or stable results. So what's the plan if the result is negative? Okay, so if this scan is not showing any change, are we going to stay the course or, consider a clinical trial, or what are we going to do? If the plant, and this is the most important question, what if this scan or test result is positive? What do we do next? And I think for me, it's easier if you've already had that discussion with the doctor, so that if you call for your test results, I can say, what have you all already decided? Because, that communication doesn't always get to me, that you're going to have this scan and you might be calling me for the result. But it's always good to know, what's your next step? Have you talked about what might be next? And I'm happy to take any questions. And yes?
So which one of these scans is the one that's used for the bones, to see the cancer in the bones?
Where I work over here at UNC, we will typically use a bone scan if the question is just about bone. If you're getting routine PET scans, if your program is like a PET total body almost scan every 3, 4, 6 months, then we may be relying on that scan. But if you come or call me with a new symptom that sounds bone related, and it's out of the blue and you haven't been scanned in a while, we will do a bone scan. Now, if there are other concerns, if you're also having other symptoms, the best scan might actually be a CT scan of the chest, abdomen, and pelvis, because the CT scan does show abnormalities in bone very well. If they're small abnormalities, the CT might miss them because it might not actually be in the cut. So a bone scan would be more sensitive for that. Yeah.
You have the CAT scan? The CAT scan is the one where you see it and it has little dark spots in the bones.
That's a bone scan.
That's a bone scan?
Mm-hmm. Yeah. So the CAT scan may have a similar finding. If there was something wrong with these bones in here, this is just a marrow signal right there. But if there were anything wrong with any of these bones in here, then you might see a black hole or a raggedy dark spot in there. Yeah. So it can look similar. But yeah, the bone scan for sure.
I guess that's what it looks like.
Yeah. So this is normal for this person. You can see that we're beginning to have some uptake in the bladder. Okay, that's how you're going to get rid of the radionuclide. So sometimes we see a nice full bladder and the tech has to get you to go empty that, come back so we can see your hips nice. And then this, of course, this is the picture that's from the back looking forward, so you're seeing more uptake in the spine. It's not abnormal, it's just more obvious on the camera. And it's nice and even, okay? There's no irregularities in that spine.
How can you tell the difference between degenerative disease and...
You ask the nuclear medicine doctor. Yeah, and degenerative change is going to be in areas where you would expect it to be. Okay, it's going to primarily be in your joints. It's going to be the wear and tear on your shoulder apparatus, your knees, your feet, your ankles, maybe even your hands, elbows. So joints is where we're going to see degenerative change. And that can also be the entire spine. So sometimes if we're seeing things and the nuclear medicine doctor is like, it could be degenerative or it could be metastatic disease, then the next best test is going to be an MRI, okay, of the area in question. Yeah. So it's hard to do a total body MRI. That would be just take hours for one thing. But one of the scans that we do order sometimes is a total spine MRI. When we do a total spine MRI, they have to do the cervical spine. Sometimes they can do cervical and thoracic at the same time, so neck and chest. But then they're going to have to move the antenna, put another antenna on the scanner to do the lower back and the sacrum. So, yes.
I'm sorry, we're out of time.
Are we out of time? I talked too much. Oh, that's terrible. That's terrible.
Thank you very much.
Yes.